this is quite a funny story. So basically, I had to get my cholesterol redone because I'm about to hit 45 quite soon, and I've been running quite high cholesterol, as Chinese people kind of do, because we like our food a bit too much, I think. But anyway, I had to go to my GP practice to just get this repeat cholesterol test done. So I made an appointment with one of the GPs. I was sat in the waiting room. There's two stories to this actually, which was quite interesting. So I was sat in the waiting room, and that GP practice where I'm registered as a patient, it's just been approved as a training practice. So they've got their first GP registrar in the practice. So I was sat in the waiting room just listening to the conversations that other patients were having about the doctors. It was fascinating. I was just like a fly on the wall. There was these two little old ladies, and the first little old lady said to the second one, she goes, "Have you seen the new doctor here? The new GP registrar?" The second little old lady is like, No, I haven't." She goes, "First little old lady, I saw her yesterday. She's so nice." Second little old lady, why is she so nice?" "Oh, she's so nice. You can get anything you want off her." Second little old lady goes, "Oh, really? I think I'll give her a go." The difference between being patient-centered and being patient-driven. You see? You open the floodgates, guess what? The flood's going to come, right? You say to that patient, "Before we talk about this headache, is there anything else you want to talk about?" "There's a million things I want to talk about today, doctor." This is what happens, right? You may still have been on 20-minute appointments, but guess what? You probably still ran late anyway, because you've got to learn how to kind of set these boundaries in place. So that sort of goes back to your question about, I suppose, being patient-centered versus patient-driven. Now, the second sort of layer to this story was quite funny, because my name then flashes up. It goes, "Nigel Giam, go and see Dr. Anila Masood." And I went, that name sounds quite familiar. But anyway, I knock on Anila's door, and she goes, "Come in." And then when she looks at me, she goes, "Oh no, I can't believe it. Oh no." And I said, what's the matter, Anila?" She goes, "Oh no." She goes, "Nigel, do you remember me?" And I said, "Yeah, of course I do. You're part of the Watford crew, right? You came on my course, what was it, about 7 years ago? There's about 4 of you." She goes, "Oh my goodness." She goes, "How do you remember that stuff?" And I said, "Look, Anila, I remember everyone I've taught, for the CSA. We spent a whole day together. We had a lot of fun. There was a lot of laughter." She goes, "Oh no." She goes, "I'm panicking. What should I do? What should I do?" I said, "Just be yourself, Anila. Be yourself." She goes, "All right, Nigel, I'll try. Okay, Nigel, here we go. Nigel, can I ask, what are your ideas, concerns, and expectations?" I was like, Anila, that is so unnatural. It's unbelievable. So I think, it's interesting for me, because you'll always have these funny stories, especially when you make, teaching very personal.
You mentioned about the statistic, and it's very interesting that it's only 30% of the international who tend to pause. So is it due to the culture and how they come across?
It's about the nuances, I suppose, of these softer skills. So there's certainly some cultural aspects to that. I mean, I'll give you a working example. So my wife, she is also a GP, actually, and interestingly, she started doing the old MRCGP back in 2006, and then she went off on maternity leave with our second daughter, and then when she came back um, towards the end of 2007, the college said, "Sorry, the old exam doesn't exist anymore. You have to do the new MRCGP." Now, my wife is from Hong Kong, so her mother tongue is Cantonese, and if you've ever heard Cantonese on the ear, it's quite a rough language. I know my wife would find me saying that, but Cantonese has only about 3 tones to it, so it always feels like quite a rough language to listen to. And so it was interesting, because my wife was obviously very unhappy that she had to do the CSA, but not as unhappy as me, because I had to get her through the CSA. And what's interesting is that when we did our simulations together, when I was helping her, when she got stressed out, although she was talking in English, and her English is pitch perfect, but when she got stressed out, it didn't sound like English anymore. It actually sounded like Cantonese. It actually sounded quite stressful to listen to. And the only way I could demonstrate that to her, because she didn't recognize that herself, was to videotape our simulations. And it was a huge eye-opener. I mean, just looking at actually how the consultation changed when you're nervous. So it isn't just about cultural issues, it's about performance anxiety. It's about recognizing that when you're put in the hot seat, what you say and what you do for all of us is not necessarily what you would say or do when you're not under pressure in real life. But you are much more likely to revert back to those technical behaviors, I feel personally, if English isn't your first language, actually, because it's a tendency that we all kind of fall back onto. And that's certainly what I've observed a lot of in people who've had issues with this particular exam. So when that's the case, I do a lot of videotaping. Everything's videotaped. I do a lot of one-to-one mentoring, and I was doing this all of yesterday with two guys who are lovely. They're both international medical graduates. One's from India, one's from Africa, but they have both failed the exam 2-3 times respectively, and they are so broken as people.
Hi, my name is Dr. Erwin Kwan. I am on a mission to dissect what makes high performers, innovators, and great leaders successful. With this podcast, I aim to share insights from interesting and exciting conversations with people who have figured it out to inspire you and empower you with actionable tips you can put into practice to hopefully improve your life.
To introduce my guest on this episode, Dr. Nigel Giam. He's a GP working in London and also the director of Mental Medicine Limited. Hi, Nigel. Welcome to the show. Could you tell us a little bit about yourself, Nigel?
Sure. So I suppose my interest in medical education stemmed from medical school. I mean, I've been in the game of medical education for a very long time. I came through medical school when it was very, very small. So I started at United Medical and Dental Schools of Guy's and St Thomas's in 1991, when medical schools were very, very small. So teaching was always very personal. I mean, the size of the medical school was only about 100 people at the time. So your lecturers would always know exactly who was there and who was missing. So you couldn't really sort of go under the radar. And I think certainly back in those days, the kind of ethos of teaching was very much around ensuring that you knew what was going on, because if you didn't, that would be highlighted. And so, unfortunately, there was quite a lot of public humiliation, sometimes on ward rounds or even in lectures, and that's obviously not the best way to teach. But it kind of made me start thinking, I suppose, about the sort of teacher that I would want to be. I mean, I don't think I ever really wanted necessarily even to do medicine. I came from a family where my parents were quite strict. I mean, very loving, but very strict. And I think certainly had aspirations for me to be a doctor before I necessarily knew that that was the career path that I wanted to follow. So I felt very much obliged almost to start medical school. And although I didn't mind undertaking medicine, I think what really interested me really was the way in which people learn. I mean, my mum's actually used to be a teacher, so I don't know if I perhaps inherited something from that side of the family, but I felt that the easiest way to learn was to actually teach other people, because in that way it kind of integrated the knowledge that you were learning yourself, and I enjoyed it as well. But sort of modeling myself on teachers that I had, it was very much around making sure that people knew their facts, because otherwise, if they didn't, that would be highlighted in front of everybody else. And one of the big things that really stood out to me was, although that was one form of teaching, it's not necessarily the best way. It can knock someone's confidence. It can really actually be quite soul destroying if you are hung, drawn, and quartered in front of other people. The way of the world, I suppose, in medicine is that we are in an era of litigation, and actually we need to recognize that the biggest critics in our lives are never ever going to be other doctors, but actually the biggest critics in our lives have always been patients. So, in order to move forward with that, one of the things that I wanted to develop was teaching that was really centered very much around patients, not driven by patient agendas, but centered around patients. And so I began to recognize that actually there are a lot of similarities between being a good doctor and actually being a good teacher. It's the doctor doctrine effect. And I think coming through medical school, you recognize quite quickly that actually you'll always remember a very good teacher. You'll always remember a very bad teacher as well. But actually, why was that teacher bad? Was that teacher bad because they humiliated you? Did they make you feel bad about yourselves? I mean, these aren't obviously great qualities in teaching, but there are certain aspects around um, reinforcement of knowledge that you can still take away from those role models, whether they be good or bad. But I think one thing that you'll never remember is a generic teacher or an average teacher. So teaching for me is very much about making sure that there isn't a one shoe fits all approach. You know, I mean, we're in an era now. I mean, just in the way we're having this podcast of being able to learn through, social media. You can learn virtually. A lot of campuses now will have virtual learning environments. Medical schools can be quite an impersonal experience when you've got a year of 300, 400 people. It's very easy. It's very easy to go under the radar for 6 years. And I think that's something that really needs kind of looking at. So for me, when I started to develop teaching, the ethos has always been it would never be a scale where I would be lecturing necessarily to a faceless audience. So, although a lot of people will teach through webinars and e-learning, and there's a lot to be said for that, that's not really me. I like very much to meet my students face to face, actually develop a relationship where one can actually support an individual at a very personal and professional level. And that's where the name mentor came from, because I think teaching goes beyond actually just getting someone through an exam or through an assessment. It's actually an ongoing skill and certainly a passion for mine. So I have many students that I've taught since the age of 18 who are now very eminent consultants. And, we're friends. We started off as teacher-student, but that relationship has evolved way beyond that. And that for me is actually the best testimonial for any teacher. So that's where my passion really sort of stems from. I think with regards to how I ended up as a GP, one of the big things that drove me into that was the opportunity to teach. I was previously a medical registrar before I became a GP, and when I was taught for MRCP, it was a very different style of teaching. It was you either know it or you don't. A lot of specialities when it comes to membership exams are very diagnostic driven, so you need to know your facts. And if you don't know your facts, then again, you'll be humiliated either by patients or doctors alike. So PACES for me was an experience where you very much were quite didactic in how you were taught and how you interacted. And I didn't feel that was really me. I certainly burnt out as a medical registrar quite quickly with rotas and not really able to kind of fulfill my passion of teaching other than bedside teaching. So GP for me, although was not my first choice, was something that I wanted to do, not necessarily because I wanted to become a GP, but because I felt that it would provide an opportunity for me to teach in the way that I wanted to teach. Continuity of care, this theme again of mentoring, and actually, as a GP, it was very encouraging because I had a really good GP trainer who really emphasized the importance of continuity, really emphasized the importance of mentoring. And so that year of internship with my GP trainer really shaped the way that I wanted to teach. I wanted to make sure that my teaching was centered around individuals, that it wasn't going to be a generic MRCP type approach. It wasn't going to be centered around the diagnosis. It was going to be centered very much around the person who's walking in through the door. And so many similarities can be drawn with obviously your patients that come in through your door. When I run a course, I don't know the 6 people who are going to walk in through my door. I have no idea what their learning styles are like. I have absolutely no idea how they're going to interact with me. And so it's almost like another day in clinic. You can't control the patients that come to see you. I certainly can't control the students that come to see me. And that for me is really empowering. It keeps it very, very fresh. Whereas I feel that if one delegates that to a sort of e-learning environment, or if the balance is tipped so much in that way, if it becomes so virtual, you completely lose that relationship. And so for me, that's it's very much about bringing medical education back to a face-to-face level. And there's some real challenges out there, I think, with regards to the messages that people want to take away as to how to pass specifically the MRCGP, which is a very, very topical exam. The differential pass rates for the exam are really tough, and we can maybe talk about that a little bit later, but the exam has been very controversial. And I've been involved, obviously, from that side of things for quite a long time also. So that's, I suppose, a bit of a brief background about myself, yeah.
That's very interesting. You've mentioned a few things I want to dig in. So you said that when you were at medical school, it was very much small number of students there. Would you be able to tell me a teacher you had then that was very inspiring, that may have stemmed this medical education seed in you at that early stage?
I mean, a teacher that really stands out to me was an anatomy teacher, actually, who is still very much alive, someone called Professor Harold Ellis, who's a bit of a legend, actually. He's now into his 90s and still teaching. Pretty much every student that's come through, which is now King's College School of Medicine, knows this teacher because he remembers everybody, from whenever he's taught you. And although, I wasn't particularly interested in anatomy, what really inspired me was the fact that he was able to recount quite clearly experiences of when he taught you. He was able to make it a very personal experience. And actually, he shared a lot of anecdotes, a lot of stories. And actually, it was this kind of narrative based approach, which I found fascinating, especially from, I suppose, a speciality which is very, very practical. That he was able to actually recount stories that really empowered him to be a better doctor, but also a better person. So it was these kind of behavioral qualities that really inspired me, as opposed to not necessarily the lecturer who knew every single fact about every single condition, because that obviously is impressive too. But those sorts of things can be sought from books, whereas actually it was much more the doctor who showed the human touch. I think that's really the thing that I'm trying to get across, that really inspired me.
When we hear stories, our brain is more engaged and we we're more stimulated to listen. Whereas somebody, if is just stating facts, then it's just a boring lecture or one of those tutorials where people are turned off.
Yeah, I mean, my teaching is completely narrative based, actually. So everything that I do from an undergraduate and postgraduate point of view is very much firstly story driven before it's symptom driven. I think one of the big challenges that we face is that from medical school we are all hardwired to always chase the diagnosis all the time. So this unfortunately is reinforced at OSCE level as well. It's a really difficult challenge.
So can you tell me, when you were in secondary school and primary school, how were you? Did you ever think that you'd become a doctor one day?
No, I was a terrible student. I was very lazy. Um, I failed pretty much most of my assessments at primary school, and when it came to the common entrance exam at age 13, I did abysmally. Actually, I almost did not make it into my secondary school. My mother at that point really took it upon herself to whip me into shape, and I've got a bit of a well, I'm from a Chinese background. My mum is very much a tiger mum. I mean, I love her to bits, but I mean, she was not impressed with my performances at all. So she invested a lot of time in getting me extra tuition, and I didn't like it. But what happened was something in my brain just kind of clicked. Actually, at that point, that actually I felt that if I could focus myself, I could actually do better. So one of my most inspiring teachers actually at that point was actually a tutor that my mum had got. So not someone who was actually within my school, but outside of school. And I think the reason for that was because I had continuity of care with her. It was a very personal, one-to-one kind of teaching. And then suddenly, actually, and she really gave me the confidence to kind of start expanding how I thought about things, applying my knowledge in the right way. And so my grades then took off. I was more interested actually in, I suppose, not necessarily the scientific subjects, although I did like biology and chemistry, but I had a real passion for geography. And I remember at the point of wanting to enter university, I was very much thinking that I might study something like that. But then when I discussed that with my parents, unfortunately, that was a bit of a no-go for them. So I was given a few options as to what I might choose, and that's how I ended up in medicine. And being the eldest out of three boys, I think that was always the aspiration that my parents wanted me to have. My father wanted to do medicine in the early 60s in Singapore, but he didn't make the grade, so he was able to do dentistry, interestingly. But I think he always wanted also another medic, or he wanted a medic in the family. So I became the first doctor of the family, as it were. So that's how I ended up doing it.
Thanks for sharing the family dynamic, because it's quite common from an Asian background to see this.
Well, it's incredibly common. So my middle brother was also and found himself down that route as well. And he now works in palliative care down in Plymouth. And I would say both he and I were not particularly happy going through medical school. So when it came to my youngest brother, my parents were like, well, I think we better leave this one alone. And he's actually a music producer, so he's gone completely the opposite way. So and I'd say he's really passionate about what he does, because he's really sort of followed his heart from the outset. Whereas I think if you become a medic and your heart wasn't necessarily in it in the first place, you have to find your way through it. But the great thing about being a GP, and I'm a real advocate for GP actually, is that it really does allow you to find your niche, because it just gives you so many opportunities. And this is what I really say to my students, is that actually you can't necessarily control where the NHS is going, but you can control your place in it. But you have to have strategy. You have to have strategy as to where you want to be. So we're on this treadmill of just churning out doctors, thousands and thousands of doctors every year. And, people have to make commitments early on. You do your foundation years, you commit yourself to a speciality. I mean, it's a bit absurd, really, if you're thinking you're a 16, 17-year-old, and then suddenly you think, yes, medicine's for me, and I'm going to do medicine for the next 45 years of my life. I mean, you're just a kid when you make that decision. You're essentially a student up until the age of 24, 25, so you've had no real working life experience handling people, managing your own life, your life balance. So then to commit into another, 30, 40 years of saying, I'm going to do this speciality is a silly thing, really. You need, people need to take a step back from that, I think, sometimes.
Absolutely, yeah. For my case, when I signed up for medicine, I didn't really know what I was signing up for. And it's one of those things, when you think about medicine from the outside, you think that it's going to be a wonderful career and it's going to be fun, but you don't really realize about the on-calls, the commitment, the sacrifices that you have to make.
Yeah, I mean, I'll give you a working example. So, I've still kept in touch with my friends from university, my best friends, who I've known since they were 18. And I'm kind of social chair for our group. But if I feel that, or kind of request a kind of social gathering with these guys, I've got to give these guys at least 3-4 months notice, just so that they can ensure themselves that they're not on call on a rota. And even then, there's no guarantee on the day that they can necessarily make it. Now, they are so passionate about what they do, and they are excellent, excellent consultants in their own fields. They're very, very eminent. But that's not for me. I mean, I think it's very much for me now getting a good work-life balance, and being able to teach also has been a massive. The fact that I can teach, and that the fact that I really enjoy it has been the biggest relief, because it's a huge outlet actually for me in the context of enjoying what I do, because I do what I love. And I think that's a really important thing that students need to understand, that it isn't this kind of lovely, easy world of patients that are going to be cooperative, the patients who you're going to have necessarily functional relationships with. It's difficult being a doctor. It's more difficult being a doctor in the NHS, because of the constraints that we face, and students need to be nurtured through that, but they also need to know the realities of that. And you start looking at, obviously, the recent doctor crises, the fact that the contract keeps changing, the goalposts keep changing, the fact that at the moment what we're seeing is not more personal care in GP, but it's delegation. Again, you've got the faceless consultation, GP at hand, Babylon, to give examples. I'm not saying these are necessarily bad things, but I mean, we are losing continuity here. The new GP contract is encouraging federation, it's massive practices, and that personal care, it's being lost. It's just being chipped away, and there's a lot of mirroring of that in teaching as well. And I'm a strong advocate of ensuring that teaching is always personal. That you always remember that one or two good teachers that you had at medical school. That for me is of paramount importance, because if you can instill that energy into someone who's as passionate as teaching as you are, then that's infectious. That just spreads, and it's a good energy. But if it's delegated to a virtual learning environment, if the balance is wrong, then that also instills a different type of energy, and I don't believe that kind of impersonal teaching is something that we should be empowering. We very much need to challenge that, actually.
I think there are some interesting points that you've made here, and I want to ask you, when you were preparing for your exams, did you find this impersonal teaching affecting how students or trainees were learning, and is that the reason why you went to start Mental Medicine Limited?
Yeah, partly. I mean, my background, I think, is quite different compared to others who are, providing, I suppose, MRCGP teaching, because I wanted to make sure that, I did it right and that I had the right mentors. So when I qualified as a GP, I joined the Northwest London RCGP faculty because I wanted to teach for the college and see how it was done. And actually, I found it a fascinating experience, because the college course at the time, to me, was very impersonal. It was a room of 60 or so candidates just being talked at, as opposed to talked with. And I think the college recognized that too. So I put myself forward to help revamp the course, which I did, and I became then a college course organizer, and then was subsequently appointed as an examiner. And we reached a point where actually the teaching became very personal. That actually, although we had 60 people, everyone was split into small groups. We had enough hands on deck in terms of examiners. Everyone remembered it as a very personal teaching experience. I mean, it reached a point, this was prior to the new MRCGP, when the old MRCGP wasn't actually compulsory, but people did it because it was deemed the exam of excellence, where, we had people flying in from Hong Kong, Oman, Dubai, because of that. At that point in time, they didn't have international MRCGP. So actually, it expanded very, very quickly. And then when the new MRCGP came in towards the end of 2006, the college really again wanted to, I suppose, get numbers through the door, but it doesn't lend itself to that. I mean, if you think about what it's testing, specifically the CSA, this is testing how you are with patients at a one-to-one level. So if you suddenly have 60 people in a room and you're trying to teach simulation, it's not going to work. It just won't. So, I piloted several courses at that point, looking again at small group stuff, but unfortunately, it didn't really sort of take with the college, who I think had a different approach, or wanted necessarily a different approach. They wanted, I suppose, courses that could be delivered at a standardized level throughout the UK, and that for me, that wasn't for me really. So, at that point, I resigned, and it was at that point I took up my training program director post at St Mary's. So I've been there now for about 11 years as the senior TPD. And that's allowed me to continue this kind of small group teaching. And mental medicine just stemmed from that, really. It stemmed from wanting to do something different, wanting to do something that was going to be a lot more personal, and something that actually was fit for purpose, specifically for the CSA. I've seen this exam evolve over the last 12 years, and I mean, you'll appreciate, I think, the controversy around this exam. There are huge differential pass rates around this, and we're losing people from this exam, which isn't right, actually. So I'm again a strong advocate of making sure that people take in the right message when they approach this particular aspect of the exam.
In the MRCGP CSA exam, there's a lot of soft skills that's assessed. The thing that you advocate is the system where you do story, symptom, and system. So you focus mainly on the behavior instead of the diagnostic technique. Could you tell a bit more about that?
Sure. Let's work through an example, okay? You're absolutely right about the soft skills and the behaviors. So, okay, let's imagine that we've got this CSA case and it's a follow-up case. So imagine we have a chest X-ray in front of us and it shows a lung cancer. We're both agreed that nothing that we ask as the doctor is going to change the fact that we're dealing with lung cancer, yeah? I think we're also agreed that in order to be assessed on breaking bad news, you've got to break it, yes? So actually recognize firstly that, that journey, that story has been started by another GP. Now, if we imagine the analogy of a car journey from A to B, this journey has been started by another doctor who's left the car. But we, as the candidate, we're getting into the car. But the patient, they're already in the car. They want to move forward, not backwards. They want their result. But we don't know our place in that patient's narrative yet. So actually, in order to break bad news, I'm not interested in the physicality of the case because, whether the patient's got hemoptysis, an unexplained cough, that's not going to change the fact that they have lung cancer. What I'm interested in, firstly, is what's happened in that journey so far. So yes, I'm going to ask what's led to the test. More importantly, I want to know what was discussed with the last GP. And actually, before I deliver the result, I want to know, does the patient actually have any particular thoughts themselves? So if we work through the scenario, Mr. Smith, before I give you the chest X-ray result, what actually led to the test? Well, I was having a cough, it'd been going on for some time, so I thought I can have a discussion with one of your colleagues a few weeks ago. So what was discussed with my colleague? Well, he'd already given me a course of antibiotics. Um, he said if it hadn't cleared up this cough, then to get a chest X-ray, just make sure that it's an infection that we're dealing with. And did you have any particular thoughts then as to why you were still having this cough? Well, I don't know. Is it an infection? I just want to get rid of it. Maybe some stronger antibiotics. At this point, you have to deliver the result. There is no point in asking questions because you want to ask questions. Because what needs to be demonstrated are those soft skills of breaking bad news. So let's imagine this. Okay, let's imagine we've got two registrars who are faced with this breaking bad news station. They're going to say exactly the same words to convey empathy, and we're going to see who passes and who fails. Now, the fact that we're doing a podcast is excellent because actually we're going to see the power of these soft skills. So I've got the first registrar, really nervous. Things haven't been going well on the CSA circuit at all. They see that chest X-ray result, they begin to panic. They bring Mr. Smith in, they sit Mr. Smith down. After delivering the diagnosis, they say, "I'm sorry." I've got the second registrar who's much more self-aware, recognizes in the next 10 minutes the message he delivers will destroy this patient's life forever, recognizes that he has a responsibility in how he delivers that message and an equal responsibility in how he helps that patient. He brings the patient in, he sits the patient down, and after delivering the diagnosis, he says, "I'm sorry." So who's passed, Erwin, the first registrar or the second?
There's no question the second registrar has done a better job.
Sure. Okay, so why then? Because as the examiner, I cannot say to the first registrar you failed because you are not empathic, because empathy is a subjective perception. So how do I make this objective? What were the objective behavioral differences between the first registrar and the second registrar? Because recognize this, in the CSA, the examiner is not looking at you. They're listening to you. Yes, because they're the backseat passenger. They need to be out of your sight. So if you start thinking about objectively what was different between those two presentations, what do you think was different between "I'm sorry" versus "I'm sorry"? Tone, timing, tempo, control, talking with, not talking at. And if we were face to face, then there would also be non-verbals, eye contact, body language. That's interesting, isn't it? Because if you want to know how these softer skills then apply to people who are having difficulties with this exam, this exam, it's a talking exam. It's a Survivor. What you're being assessed on is not what you say, it's how you say it. And actually, if you start thinking about what we do in general practice, I don't know if you've had a GP placement already, but you'll recognize that soon when you start as a GPST3, that there is no magic drug, that actually you're the drug, that actually the way in which you make a patient feel better depends on how you make them feel. And that depends on how you feel. It's about energy. It's about transference. I mean, have you had a GP placement yet?
I've had a GP post. The last post was my GP post, and I'm currently on pediatric post
Sure.
now. Yeah, I've had the experience, and I've seen when patients are desperate and you don't have a magic pill to give them, and you have to talk to them, and that's a therapy there.
Yeah, talk with them, not talk at them, though. That's the key. And I think you may have recalled perhaps a GP clinic where you saw 3 or 4 depressed patients. I mean, all of us have one of those days, but if you don't have the right energy, then the only person who's going to be depressed at the end of that clinic is you. Because it's transference and countertransference. I mean, I had a clinic last year where I saw 4 depressed patients. Okay. Which in itself wouldn't have been so bad, but for some bizarre reason, all the depressed patients were booked back to back. Yeah. And so by the time I saw the 3rd depressed patient, I was like, I'm so depressed. I mean, I'm so depressed. I don't think I can see another depressed patient. And when I brought the 4th patient in, I sat down. Before we even started, the patient looked at me and went, "Are you all right, Dr. Giam? You look terrible." "Yeah, I feel terrible. What do you want?" "Oh, I'm depressed." "Oh, all right, okay." So, you have to counter sort of nervous energy with positive energy, and that's the problem in the CSA. When you're in that hot seat, you'll say things, you'll do things that you wouldn't usually say and do. And the massive issue is there are so many mixed messages out there. This is not a diagnostic-driven exam. It never has been. I mean, to understand this, it's very easy. Look at the 16 competencies that the CSA is assessing you on. Competency 6, which is the working diagnosis, that is only one competency out of 16. And specifically, the CSA examination summary report, which was published 5 years ago, highlighted that there will always be cases in the exam where there is no clear diagnosis whatsoever. What we're interested in is how you manage risk with patients, how you share risk with confidence. Reactive practice, not defensive practice, reactive practice. So it's about managing people, not diagnoses. That's the key to passing, and so it relies on those soft skills, absolutely. If you look at the differential pass rates, and I don't know if you're aware of this, but the Royal College have differential pass rates on the people that sit this exam, and these have existed since the conception of the exam. If you're English white female, then the likelihood of you getting this exam on paper, according to the MRCGP, is about 80-85% first time pass rate. If you're British ethnic minority, it falls down to about 70-75%. But if you're an international medical graduate, specifically if you've done your medicine overseas, and if English isn't your first language, then it falls down to about 30%. That's a huge drop. It's massive. And I think people need to recognize what's going on there. And I certainly think there needs to be the right mentoring and support with people who are having issues with this exam, because it is a talking exam. It's a linguistic exam in essence. It isn't just about your clinical acumen, because I've seen thousands of doctors, thousands. I mean, for this particular aspect of the exam, the CSA, I've been teaching this now for 12 years, so I've taught about around 8,000 ST3s through this process. So I observe the behaviors of all of these guys, and what's interesting is that when you are nervous, and specifically actually if English isn't your first language, you are much more likely to lose that natural tonation. You are much more likely to actually talk quicker, talk at the patient rather than with the patient. You're much more likely to fall back on technical language. So it is very much about how you control those behaviors, because it is a viva. It's a talking exam.
So you mentioned about the statistic, and it's very interesting that it's only 30% of the international who tend to pass. So is it due to the culture and how they come across?
It's about the nuances, I suppose, of these softer skills. So that there's certainly some cultural aspects to that. I mean, I'll give you a working example. So my wife, she is also a GP actually, and interestingly, she started doing the old MRCGP back in 2006, and then she went off on maternity leave with our second daughter, and then when she came back um, towards the end of 2007, the college said, "Sorry, the old exam doesn't exist anymore. You have to do the new MRCGP." Now, my wife is from Hong Kong, so her mother tongue is Cantonese, and if you've ever heard Cantonese on the ear, it's quite a rough language. I know my wife would find me saying that, but Cantonese has only about 3 tones to it, so it always feels like quite a rough language to listen to. And so it was interesting because my wife was obviously very unhappy that she had to do the CSA, but not as unhappy as me because I had to get her through the CSA. And what's interesting is that when we did our simulations together, when I was helping her, when she got stressed out, although she was talking in English, and her English is pitch perfect, but when she got stressed out, it didn't sound like English anymore. It actually sounded like Cantonese. It actually sounded quite stressful to listen to. And the only way I could demonstrate that to her, because she didn't recognize that herself, was to videotape our simulations. And it was a huge eye-opener. I mean, just looking at actually how the consultation changed when you're nervous. So it isn't just about cultural issues, it's about performance anxiety. It's about recognizing that when you're put in the hot seat, what you say and what you do, for all of us, is not necessarily what you would say or do when you're not under pressure in real life. But you are much more likely to revert back to those technical behaviors, I feel personally, if English isn't your first language, actually, because it's a tendency that we all kind of fall back onto. And that's certainly what I've observed a lot of in people who've had issues with this particular exam. So when that's the case, I do a lot of videotaping. Everything's videotaped. I do a lot of one-to-one mentoring, and I was doing this all of yesterday with 2 guys who are lovely. They're both international medical graduates. One's from India, one's from Africa, but they have both failed the exam 2-3 times respectively, and they are so broken as people, so broken, because they're coming to me saying, I know everything about the diagnosis. My knowledge base is up to date. I've got really good feedback from my trainer, from my patients. So I just don't understand why I'm failing. And 15 minutes of videotaping under pressure, and when they look at that, then you suddenly recognize, okay, so that's what's going on. And I had no idea that was actually what was going on, because no one's actually sat down and taped that and showed me those softer skills and showed me those behaviors and actually put those behaviors into black and white so that I can actually work on that from an objective point of view. And the best testimonials I get are not, oh, I passed this exam with 110 marks. The best testimonials I get are, this has changed the way that I consult in real life too. I don't feel as stressed. I react much more to the narrative that's in front of me. I'm okay with not having an answer at the end of it because I'm working in collaboration with my patient. I don't need to know the diagnosis to manage that person. I'm not afraid to have negotiations. I'm not afraid to step up to challenges. I'm not afraid to say no, actually, to patient demands. This is really the best feedback any teacher could get from teaching for this exam, because at the end of the day, it's just an assessment. The bigger challenge is surviving and being happy as a GP after this. And I don't think you can delegate that personally to a webinar or e-learning. I mean, that might sound very arrogant, but that's just the way that I think about it. I'm very passionate about what I do. I don't think you can learn these softer skills by doing a cramming session of 120 cases from a book or anything like that, because it's not driven that way. It just isn't, and real life isn't either.
I really like this philosophy where you're nurturing your student and taking the time to listen and identify what's a problem, and then being able to make a plan with them and help them to see a different side of how they can approach things.
The thing here is we are hemorrhaging GPs at the moment. We're 1,000 less GPs nationally this year compared to last year. We cannot simply afford to lose more people. You know, it's not good enough to say to somebody who's failing, you know, you'll be fine, you're a very nice person, you should be okay. That's not good enough when someone has failed the exam 3-4 times and they're already £10,000 in debt. It isn't good enough to say you'll be fine. It isn't good enough to give false reassurances. You know, what people need is the right mentoring and support and objective areas in which behaviors can be changed to empower that person to take ownership of where they want to be. Because I've seen too many fatalities through this assessment, to the point where one actually has to question whether this really is the right assessment for people. Because personally, and I know this may not sit well with some people, but this the CSA isn't really a valid reflection of what we do in real life. Because in real life, when a patient comes in, you're not nervous, and in real life, when you say to that patient, "Tell me more," they're going to tell you they're going to tell you a lot of things. When you say any other symptoms, they're going to tell you. When you say anything I've missed you want to talk about, they're going to tell you. Whereas in the exam, when you say "Tell me more," it's met with, "What do you want to know?" Any other symptoms? What does that mean? Anything I've missed? You've missed plenty, but I can't tell you unless you specifically ask me. And this doesn't reflect what we do in real life. So I think it's all about strategy. But the strategy is not about knowing the diagnosis. It's about knowing how to open up a narrative. It's about being curious. So it's just about using skills that we do have in real life, but making sure we have the right strategy to apply them, to a high stakes assessment. And that's what really fascinates me and actually still keeps me going. It's not about, what's the next new case I'm going to write up. Because my cases are written up from people that I've met in real life. They're based on real people. They're not based on diagnoses. I mean, as examiners, we don't sit down and go, let's write up a case about atrial fibrillation. That's not how it works. It's about, I saw a really interesting patient the other day who just so happened to have atrial fibrillation. Oh yeah, what was the cause of their atrial fibrillation? Oh, he was a crack cocaine user, a 22-year-old crack cocaine user who's an atrial fibrillation. Now that's a story. So that's really how people have to approach this exam. That it's narrative driven. It's not diagnostic driven. Because the great privilege of being a good GP is we're allowed to dip into patient stories. We're allowed to help move those stories along. We don't always have a solution at the end of that, but we've been part of that patient's narrative, and that's the best thing of being a good GP, I think.
Interesting, yeah. So, in your experience of mentoring thousands of students, where do you see students or GP trainees wasting their time?
Books, just doing. I mean, specifically, if you're talking about the CSA, the key here is there is a difference between working hard and working smart. At Mary's, my trainees only practice about 30, 40 cases, the same cases again and again and again and again to get their behaviors right, their qualitative behaviors right. They practice their feedback, they calibrate their feedback. The tendency in study groups is to be far too nice. So you do a case and then the feedback is, "Oh, you're really good, you're really nice, let's do the next case." On the day, when you have to do the examination, the examiner, they're not going to give you examination findings unless you actually examine the patient. In study groups, when you sort of go, "Can I have my examination finding?" Immediately, "Oh, here are your examination findings." That's not going to happen on the day. It's like, hold on a second, you need to examine before I actually give you anything. So it's all about strategy. And I think the problem here is, I mean, there are so many mixed messages out there, and there are thousands of resources to the point where it becomes confusing. But if you pick any resource for this exam, which is symptom-driven, diagnostic-driven, and you go by what the book tells you, you're going to be lost very, very quickly. Because what will happen is you will focus on the diagnosis. And as a result of that, you're going to end up talking at the patient about a diagnosis as opposed to managing a patient with a diagnosis. Because when you're managing in general practice, you're not managing diagnoses, you're managing people. You're managing people with stories. The diagnosis is secondary. I mean, if I see somebody who's coming in with a life-threatening problem, the issue is not the fact that it's a life-threatening problem, because that's the thing that you should spot easily. The thing is, will they go to hospital? I mean, if you say to anybody, are you happy to go to hospital? Do you think any patient's going to say, I'm happy to go to hospital? No patient's happy to go to hospital. They're more likely to be very unhappy. Actually, they're very likely to be scared. So spotting the admission in the CSA should be easy. The dilemma is, can you negotiate them or advocate that admission? Can you manage that person, that patient, their anxieties, as opposed to just the diagnosis? So, it's very much about bringing that level of reality and emotion to study groups. And that's difficult because, we're not actors. But the way I encourage my registrars is, think of someone, before you even pick up a book, think of somebody that you've seen in a real life consultation, someone who has challenged you, from an emotive point of view or from a risk management point of view. That's your CSA case. Bring that back to the study group. And in that way, actually, it becomes much more real because it empowers people to actually learn from behaviors and actually take those behaviors back into real life to manage patients in real life. So that's my kind of philosophy around it.
There's a proverb that says that we don't raise to the level of our hope, but food to the level of our training. So having tough training really helps.
It's tough love. The era I was brought up in, it's always been tough love. It's been tough love from my parents. It was tough love at medical school. It was tough love being a med reg. It was tough. It's still tough love. But at the end of the day, it's love. To me, the only two transparencies you can ever pay with are honesty. Two currencies rather, that you can pay with are honesty and transparency. Because I just feel that sometimes people aren't honest enough when it comes to feedback. People aren't transparent enough. And if you give somebody false hope, that's the worst hope to give, actually. There's always hope. But false hope, that's a different matter.
That's a disservice to that person.
Absolutely, because, the exam is very costly. You're forking out 1,003, 1,004 just for the privilege of sitting the CSA. When you go into that exam, you want to know that you've been prepared in the right way. You want to be prepared strategically in the right way. And strategy is all about behavioral strategy for this exam, not diagnostic strategy.
There's a lot of work that you need to be doing in the mindset of the registrars when you have them to train them.
Yes. I wear many hats. Obviously, I've got mental medicine, but, primarily I've always been an educator for the School of General Practice and, what now is Health Education England. So, my interest very much is not just about mentoring trainees, it's about mentoring trainers as well. So when it comes to preparing for assessments like this, the thing for me is that it's actually much more about making sure my trainers understand how to help in the right way because of the mixed messages. Because, the exam's not a cot. In a cot, you can ask lots of open questions, golden minute of silence. The CSA doesn't work that way. There's no golden minute of silence. Every minute you're in the exam costs you about £20. So you get a very expensive minute of silence. There's no golden minute of silence, So it's about, teaching trainers that there are rules that work in COTS and there are rules that work in CSA. But they're all based on behaviors. In both instances, the behaviors have to feel real, but they just have to be strategic for the nature of the assessment.
So some common misconceptions you find is that people think that it's a COT and they think that it's like a diagnostic test. Are there any others that you find people saying that you hate hearing?
Yes, that they think that, when it comes to the management, it's all about, making sure you know exactly what NICE guidance is about. No, the AKT tests that. Yes, for sure, whatever you practice has to be in line with what we would deem evidence-based, but the management plan is not the management of the diagnosis, it's the management of the patient first and foremost. The other really massive misconception is that you've always got to keep your patient happy. We're not, we can't be living in a sort of consumer-driven society in the NHS. You will have seen this patient yourself when you were doing GP, but, Mr. Smith who comes in and goes, "Oh, it's so easy, doctor. I just want an antibiotic. Oh, and you know what, doctor, today you're going to give me that antibiotic." Yes, I mean, we've all seen that patient, haven't we? And when we see that patient, our immediate sort of reaction is, all right, Mr. Smith, I'd rather die than give you that antibiotic today. So we always, almost putting ourselves up for a fight. But actually, the reverse of that is because we're not, we're generally pretty nice people as GPs. We don't like confrontation. We sort of go, oh, well, there are 3 options, Mr. Smith. Option 1, should we see how it goes? No. Okay. What about a delayed prescription? No. Okay. What about if you keep shouting at me, I'll do what you want? Yeah. I'm definitely going for option 3. So there's a huge difference between being patient-driven and being patient-centered. Being patient-driven is doing what your patient wants you to do. Being patient-centered isn't about saying, here are options, you pick. That's got nothing to do with being patient-centered. Being patient-centered equates to negotiation. It equates to readdressing patients' agendas. It equates to working through the dilemma of want versus need. And I think the sooner that people recognize this, even at medical school, the sooner that people recognize this as students, the sooner you're going to be better prepared to work in the NHS. Because as med students, there's no lecture on negotiation skills. I mean, we are negotiating all the time. I'm sure you recognize this when you were in your GP placement, that a lot of the time you have to say no. But it's how you say no. And it's also about, if you're going to say no to something, what can you actually barter with? What can you negotiate with? So, I think it's really important that we recognize that, and especially at medical school, that actually you're coming into a system where you're not going to be able to meet the demands of patients. It's just not possible. You have to always find the compromise. That's what's being patient-centered.
There's a lot of communication skills that we develop as doctors, and as you were saying, with seeing patients every day, I'm sure there is some transferable skills that you will have in business and setting up mental medicine. How did you find it as a doctor to set up a business?
It's interesting because I'm not a natural businessman at all, and I didn't set up mental medicine with the view of making it a business. I feel I'm very lucky because it just has evolved into that. Money for me has never been the driving factor. I've never wanted to go for quantity ever. It's always about, for me, quality. So, I'm very happy just teaching, paid, unpaid. It doesn't really matter for me. I want to teach. I've always wanted to teach. The thing that has been most transferable, though, if you're asking me from a business acumen point of view, is to really understand the person that's coming to see you. Because if you understand that and make it personal to them, then you can't lose. You just can't. And that's the same as a patient. You need to understand that person who's walking in through the door. I think as soon as you delegate that, you make it into something impersonal. I mean, if you imagined, a patient comes to see you and you sort of say, oh, actually, I don't need to see you. Here's a patient information leaflet. Go and read that. It's a bit like, someone comes to see me for the exam and go, well, you don't need to see me. Go and look at that webinar of 120 CSA cases. It just loses that kind of personal touch. So the biggest thing for me in why this business has become successful is because, I mean, this may sound a little bit arrogant, but I don't forget the people that come to see me. Out of if someone from 8 years ago now contacts me, who's come on my course or come to see me for mentoring, they will always go, you probably don't remember me. And I will go, actually, no, I do remember you. I absolutely remember you. I'll give you a working example. This is quite a funny story. So basically, I had to get my cholesterol redone because I'm about to hit 45 quite soon, and I've been running quite high cholesterol, as Chinese people kind of do, because we like our food a bit too much, I think. But anyway, I had to go to my GP practice to just get this repeat cholesterol test done. So I made an appointment with one of the GPs. I was sat in the waiting room. There's 2 stories to this actually, which was quite interesting. So I sat in the waiting room, and that GP practice where I'm registered as a patient, it's just been approved as a training practice. So they've got their first GP registrar in the practice. So I was sat in the waiting room just listening to the conversations that other patients were having about the doctors. It was fascinating. I was just like a fly on the wall. There was these 2 little old ladies, and the first little old lady said to the second one, she goes, have you seen the new doctor here? the new GP registrar. The second little old lady, like, no, I haven't. She goes, first little old lady, I saw her yesterday. She's so nice. Second little old lady, why is she so nice? Oh, she's so nice. You can get anything you want off her. Second little old lady goes, oh, really? I think I'll give her a go. The difference between being patient-centered and being patient-driven. You see? I mean, when you were a GPST2, you were on what, 20-minute appointments, 25-minute appointments? Something like that.
I started with half an hour and then 20 and 15, yeah.
You open the floodgates, guess what? The flood's going to come, right? You say to that patient, before we talk about this headache, is there anything else you want to talk about? There's a million things I want to talk about today, doctor. This is what happens, right? You may still have been on 20-minute appointments, but guess what? You probably still ran late anyway, because you've got to learn how to kind of set these boundaries in place. So that sort of goes back to your question about, I suppose, being patient-centered versus patient-driven. Now, the second sort of layer to this story was quite funny, because my name then flashes up. It goes, Nigel Giam, go and see Dr. Anila Masood. And I went, that name sounds quite familiar. But anyway, I knock on Anila's door and she goes, come in. And then when she looks at me, she goes, oh no, I can't believe it. Oh no. And I said, what's the matter, Anila? She goes, oh no. She goes, Nigel, do you remember me? And I said, yeah, of course I do. You're part of the Watford crew, right? You came on my course, what was it, about 7 years ago? There was about 4 of you. She goes, oh my goodness. She goes, how do you remember that stuff? And I said, look, Anila, I remember everyone I've taught, for the CSA. We spent a whole day together. We had a lot of fun. There was a lot of laughter. She goes, oh no, she goes, I'm panicking. What should I do? What should I do? I said, just be yourself, Anila. Be yourself. She goes, all right, Nigel, I'll try. Okay, Nigel, here we go. Nigel, can I ask, what are your ideas, concerns, and expectations? I was like, Anila, that is so unnatural. It's unbelievable. So I think, it's interesting for me, because you'll always have these funny stories, especially when you make, teaching very personal. And, just in the way that, it's very fashionable now as doctors to become authors and write about the stories of the patients that they've seen. It's all about stories. The people that you teach, the people that you remember. There are many stories to this. Some of them are great, very happy. Some of them are sadder, but inevitably you use them as a teacher to empower yourself to help people in a better way. So, that's my ethos. It's pretty plain and simple.
I love that philosophy. Yeah, I think whatever we do in life, it's all about the people, the connection we've made, and the relationship. I still remember from previous placements, and even if it was a hard placement, really busy, and I found that when you had a good team and the people you were working with work in really good harmony, then it's something that you will always cherish when you think about it.
Yeah, no, absolutely. And I think the other thing for me is it's about teamwork, because I don't work in isolation with this at all. I mean, I know a lot of other guys do, but I that for me has never been an option. What's very interesting about Mentorship, the undergraduate course that I run, is that all the tutors that come back to Mentorship are students that I've taught before in the past, whether they're now senior registrars or consultants, because that is the ethos of mentoring. It's about empowering the next generation and the next generation and the next generation. So, that, and I've got the most amazing friends and colleagues through teaching. With Mentor MRCGP, exactly the same. I've got, although it's me that delivers the teaching, the team of actors and actresses who work with me, these guys have been with me for well over 10 years now. We're a family. We are a family. We work together. We have our arguments. We will disagree on things, but we work through it, because that's what we enjoy doing. When I wake up and I'm running a course tomorrow, that's not work for me. For me, that's me going to meet my family and having a good time and inviting people into our home. We're inviting students into our home, and we're going to be hosts, and they're our guests, and we want to do the best by them. That's always been the ethos of how I teach. That's the thing that keeps me going. I'm not here to teach thousands and thousands of people. That was never the case. The ethos for me has always been, I'm not here to change the world. I'm not here to change the world. What I'm here to do is if I can help one person, just one person, change something significantly for them in their lives, then my job is done. That it's as simple as that. That's always been the driving force for me. It's never been about quantity. It's always going to be about quality.
One of the things I read on your website is that you have this fun aspect to your course. How do you incorporate that?
When you come on a high stakes sort of simulation type course, there's going to be a lot of nervous anxiety, a lot of performance anxiety. So the actors that I use are very comical. They're very funny. We use a lot of humor. A lot of humor has been written into cases so that people can actually have fun with it. They can actually laugh at their mistakes rather than punish themselves. I think we're in a profession where if something bad goes wrong, we're always punished for them. There's always some underperformance or investigation or serious event or significant event analysis, and it becomes a very scary thing. I mean, we're only human beings. At the end of the day, we're all going to make mistakes, but to be able to take a step back and actually laugh at your mistake, I think is very important. To be able to do that will allow you to learn from it. Whereas, the era that I was taught in was that every time I made a mistake, I was punished for it, and that does nothing for your confidence. It just kills off that passion even further. Whereas if you're empowered, if you're actually given permission to say, well, you know what, you can actually laugh at that because it's okay, it's a safe environment, then actually you're going to learn a lot more because you won't act empathic, you'll just be empathic. So for me, humor has always been a very important aspect to what I do. The stories that I share, the ones that I just shared with you just then about, this poor girl who got so scared that she saw me that she reverted to, ideas, concerns, and expectations. That for me is really funny. And when I was talking about that to her, she herself was laughing so much. She just goes, it was just so funny. But I just put myself back in that CSA chair again, and I said, I know, but why did you do that? Because you've already passed the CSA. So it's important to just have a really good laugh about it, because if you can't have a laugh out what you do, then you're just going to burn out with work. I think people sometimes just take it too seriously, really.
Absolutely. I want to shift gear now. Let's go in the rapid fire questions. I'll ask you some question and you tell me the first thing that comes into your mind. What is your definition of success, Nigel?
My definition of success is being able to know that what you've done, you can be proud of. It's really as simple as that. It can be being a good dad, being a good husband, and knowing that you've done right by your family. It's very simple.
What book have you read that has completely changed your mindset on life?
I can't choose any particular book, but every day I will sort of open up my little book of Confucian quotes and just let that bring me back down to earth. I mean, if there was a particular book that I would choose, it would be by a neurosurgeon who unfortunately passed away, and it's something along the lines of, I can't remember the title completely, but I think it's when air becomes breath, and it's a story about a neurosurgeon, a very successful neurosurgeon who had everything planned ahead and then was diagnosed with cancer at a point where he just got married and was hoping to start a family. And it's his diary, really, of his last days and his insight into what he wished he could have done. That actually success wasn't going to be defined by, the fact that he was going to be the youngest neurosurgeon ever, but actually, that it can be defined in so many different ways. And it's such a heart-rendering book. I mean, if anyone reads it, they'll be in tears after the first couple of pages, because it's just, again, about that human touch.
Have you dealt with what seemed to be a crisis at the time, which later turned out to be a blessing in disguise?
Plenty. I could talk about this for ages, absolutely ages. I was involved in a horrific road traffic accident about coming up to almost 11 years ago now. 10 years ago. It was the day before my first daughter was going to turn 1. I was due to lecture at Guy's and St Thomas's, and I was tired. I live in northwest London. I had to get to southeast London, and I got onto my motorbike when the weather was not good, and I was half asleep, and I got taken down by an articulated lorry. So I suffered some pretty horrific injuries, and I was in a wheelchair for a couple of months, not knowing if I was going to walk again. And that was a huge wake up call. I mean, that was a day before my second daughter's first birthday. I could have missed all of that. That for me was a life-changing event. And what was very interesting is the first person that I saw, the paramedic that came to see me, he could see that I was in a state of shock. But actually, as we was talking, as I was put into the ambulance, I was obviously very somber. He said, one day you'll look back on this and you'll see this as a blessing. And I thought the guy was crazy. When he said that, I was like, I don't even know if I'm going to walk again. How on earth can you say that this is going to be some kind of blessing?
How was the rehabilitation period?
Very protracted. I mean, when you're kind of just sat looking at the garden for a whole day, it gives you a lot of time to reflect on what could have happened, what should have happened, what may happen. I think it's sort of come to a point now where I'm much more sort of what will be actually, and I'm happy with where I am. I don't define success as being commercially viable. I never have. I from a teaching point of view, I define success as if students have gone away and they remember this as something memorable, something they can encompass into their own lives in terms of the stories that they've heard, then that for me is success.
Thanks for sharing that, Nigel. And what is happiness to you?
Happiness is very much about being at peace. It's about being at peace with yourself, your inner demons. I think anyone who ventures into business is always going to have demons. Am I going to be all right? It's just very much about being able to wake up, enjoy what you do, be passionate about what you do. I'm very fortunate. I've got a very supportive family. I've got very lovely children. I've got an amazing partner. I'm lucky. For me, I've struck the lottery. That for me is happiness.
A very important thing in life is to be able to appreciate what we have. And too many times we chase and go and try to find happiness somewhere else when it's already there.
I think the thing is, if you put happiness on a pedestal, you put this goal that you're always trying to reach, you'll never ever reach it, actually. And even when you get there, when you get to that summit, you're going to recognize it wasn't quite what you were expecting anyway. So I think it's important that you just recognize and appreciate what's in front of you, because, as you say, sometimes it's just there, actually.
It's been a real pleasure to have you on my podcast, Nigel. Where can people find you?
Thank you. I mean, I don't have a huge social media presence, but we certainly have a Facebook page, and I try and post little quotes or narratives from the courses that I run. So that's Mentor MRCGP, the website, which is www.passmrcgp.com. We've got a little YouTube channel which focuses on behavioral strategy. I'm on Twitter as well. And yeah, I mean, you can contact me by email. I'm happy to have conversations over the phone. I'm very, very accessible. So yeah.
If you enjoyed this video, smash the like button. If you have not already subscribed to the channel, I invite you to subscribe and hit the notification bell so you don't miss any future videos.